Yeah, Hello everyone. Welcome to the session on malaria again. This is part 2, and this is Dr. Waheed Hussain taking the session. And last time you remember that we stopped by explaining the etiopathogenesis and the clinical spectrum of the malaria which can happen in children, including tropical splenomegaly syndrome and including the congenital malaria. All right, and we included all the complications which can occur in malaria. Okay, and now we'll be going towards the diagnosis per se. All right, now diagnosis, as you know, microscopy microscopy is the most traditionally used technique and the gold standard. Okay, microscopy. Now what do you see in a microscope? All right, like, is there any what exactly are you looking for the microscopy? Now along with the microscopy, in microscopy you will be looking at the smears. Okay, the smears for the microscopy. All right, along with this there is many RDT kits. I'll explain each in little detail later on. RDT kits are available in which parasite antigens are tested. Okay, and then there are certain CSF findings which you can find in cerebral malaria, which I'll mention here itself. The CSF findings in cerebral malaria when compared to bacterial meningitis was okay, wait, I'll write it in this way. I'll write it this way: cerebral malaria versus bacterial meningitis. Okay, when you do cerebral malaria versus bacterial meningitis, you will find in cerebral malaria mild pleocytosis. Mild pleocytosis. Okay, this is the main difference, how you will differentiate a cerebral malaria case with the bacterial meningitis case. Now, if you have to do cerebral malaria versus viral encephalitis, that is VME. Okay, VME, you will find that there are in cerebral malaria lower CSF glucose level, lower CSF glucose, higher protein and LDH levels. Okay, and CSF to blood LDH ratio will also be high, and CSF to serum ADH ADA ratio will also be high. So CSF to blood ratios, which ratios? LDH ratio and ADA ratio, serum ADA ratio, these two will be higher in cerebral malaria compared to the viral encephalitis. All right, now coming to the microscopy per se, microscopy, which is the gold standard I have told. Now there are two types of smears you need to know. There is a thin smear and there is a thick smear. If your ward has the collection of smears there itself, definitely in the bedside ward you might have seen the collection of the smears, and at the same time you might have seen it in the NVBDCP lab which is present in your institute. Now what they do in this is they take a slide and they take a puncture. Either they take the punctured blood, that is capillary blood, or sometimes if you are not getting from the capillary blood, we'll go for the venous blood sample. Whatever blood sample we take, we make one drop here and one drop here, and this one drop with another slide will make it into a tongue shaped normal smear. Okay, so this will be a thick smear, this will be thick smear, and this will perform as thin smear. Okay, now what do you do to this thin smear or thick smear? What do? Uh, you do something called as fixation with methanol fixation. Now what does this methanol fixation do? This methanol fixation will identify the large RBCs which have been invaded by the parasites. Okay, this methanol fixation helps us to visualize or identify invaded large RBCs with parasites. Okay, and even speciation also it helps, methanol. All right, and you can see in oil immersion magnification, that is into 1000, that is In this, intra-erythrocytic parasites are seen, which are even in the early stages, that are young stages. Young stages, intra-erythrocytic parasites are seen in this oil immersion field. And which stain do we prefer? We prefer GMSA stain when compared to right stain. Okay. Why? Is there any reason that we are using GMSA stain over right stain? Because GMSA stain will preserve something called as Scuffner's dots. Scuffner's dots are preserved in the GMSA stain in P. vivax and P. ovale. Now, as you know, what is the use of thin smear and thick smear? Thick smear is used to identify the parasitemia, whereas thin smear is used for speciation. Okay, so thick smear have a higher sensitivity, whereas thin smear have more specificity. Okay, and then there is something called fluorescent microscopy. Okay, sometimes we can go for fluorescent microscopy. In fluorescent microscopy, we can see the quantitative Buffy coat test, which is stained with acridine orange. Acridine orange. Okay, this is about the smear. Okay, and now let us go to okay, we'll go to detection of parasite antigen. This parasite antigen detection of parasite antigen. This parasite antigen detection is done by immunochromatographic assay. Okay, this assays will detect HRP2. What is HRP2? Histidine rich protein 2. Okay, these are specific to falciparum actually, whereas if you take LDH or HRP2 along with aldolase, this can be present in all 4 species. HRP2 is more specific to falciparum overall, but if you take LDH or HRP2 plus aldolase, all 4 species will be covered. Now, the LDH based assays which are there, available LDH based assays, this will differentiate between the viable versus non-viable parasites and are helpful in monitoring the response to therefore therapy. So, by therapy you will know how many are alive, right? Okay, now next you will be talking about DNA probes. DNA probe methods are also there, which are mostly for falciparum. Okay, and PCR. PCR is there. PCR is sensitivity, specificity is 100%. 100% sensitivity, 100% specificity. Okay, and the only method known to diagnose NULC. Only method known to diagnose NULC. Then we can use something called as flow cytometry sometimes. Okay, what is flow cytometry used here? Flow cytometry is used to display cells which contain the malarial pigment as a population which is distinct from the other cells. So they will see the malarial pigment, okay, malarial pigment, and which cells contain this versus the cells which don't contain this. So you know how flow cytometry appears, right? So it's shown to display cells containing the malarial pigment as a population distinct from the other cells using flow cytometry. And then there is antibody detection. Antibody detection. What is happening in antibody detection? Antibody detection is only useful to diagnose non-immune individuals with cryptic febrile illness. Cryptic febrile illness. If anyone non-immune individual has a cryptic febrile illness, it's very useful to use antibody levels, and it has even a role in hyperreactive malarial syndrome or tropical splenomegaly syndrome. Okay. Now CBC, we discussed CBC, right? In CBC you will find anemia, you will find thrombocytopenia, and sometimes thrombocytopenia may be the first manifestation, and anemia may be severe, it may be mild, it may be moderate. All right. Now an important finding which I have seen in my PG, I have seen 2 cases over the course of 3 years in my PG which presented with very high TLC count, and a case which has an anemia, some mild amount of thrombocytopenia, okay, and very high TLC, along with sick child, okay, and he was having definitely pains, abdominal pain, body pain, leg pains. So definitely when this picture presented to us in my postgraduate, one of our main differentials became malignancy actually, okay, malignancy. And when we sent this to the smear, they even said that this were reactive lymphocytes, well, we were not sure, okay, what was exactly happening. The child did not show any blast cells, there were no any abnormal manifestations, okay, there was no weight loss, and the history was quite acute, like only just that can also be a differential still. Malignancy can still be a differential even if fever is for 4 or 5 days. uh, so we went on, and when they did the smear came positive, malarial falciparum, we got PFR positive, okay, ring form positive, we got plasmodium falciparum ring form positive. And then when we gave the treatment to the child, immediately this TLC count fell. So definitely, even though rare, I would like to write this, that I have seen, and 2 cases of leukemia reaction in my ICU, which was due to falciparum infection. So this is out of experience I'm saying, not a very common finding, but definitely this can be a presentation. So I wanted to mention because this is out of my experience, personal experience. Okay, this was a side note. So I'm coming back to treatment. In treatment, I won't be explaining in detail how do we manage a sick child, all right. I'm not going to mention about what to do about the anemia, okay, like we will be giving transfusions in a case who is sick, all right, a case which is sick with severe anemia, splenomegaly, malarial positive, okay, having CCF sometimes because of the anemia, all right, presenting in a sick state, okay, unstable vitals, we have to correct all the vitals, shock, all these things are there, algid malaria, all these things I won't be discussing. I'll be discussing only uh, the anti-malarial treatment per se, okay, and the protocols and the regimens, okay. In treatment, first thing I'll try to talk about is classification of the drugs, okay. The classification of drugs which you should know is 2 types. One is clinical classification, one is pharmacological classification or chemical classification, okay. In clinical classification, I'll mention clinical classification. We have number one, causal prophylactics. Now, what are causal prophylactics? Causal prophylactics are the drugs which prevent maturation of or destroy the sporozoites within the hepatic cells. Okay, these are primaquine, pyrimethamine, and proguanil. Okay, then we have number 2, suppressives. Now suppressives are of 2 kinds, rapid acting and slow acting. Okay, now what are suppressives? Suppressive inhibit the erythrocytic schizogony and the rupture of infected erythrocytes. Therefore, they lead to what? Clinical cure. Clinical cure, that is freedom from the fever and rigors. In the rapid acting, we have quinine, chloroquine, amodiaquine, mefloquine, artemisinin, okay, atovaquone. In the slow acting, we have proguanil, pyrimethamine, and sulfadoxine. Okay, so this is about suppressives. Number 3, we have the radical curatives. Radical curatives. Now, what are radical curatives? They eradicate both erythrocytic and exoerythrocytic schizogony. Okay, erythrocytic as well as exoerythrocytic schizogony. But problem with this is sorry, not the problem. The advantage with this is there will be no relapse. Why? Because you are even killing the exoerythrocytic stage, means liver stages are killed. So therefore there won't be any hypnozoites. If there are no hypnozoites, there will be no relapse. So this cause freedom from relapse. Radical curatives, freedom from relapse. What are the drugs you know? Primaquine and proguanil. Okay. Next, number 4 is gametocytocidal. Gametocytocidal. For gametocytocidal, for all species we have primaquine. For all species except for falciparum, we have chloroquine. Except falciparum, we have chloroquine, quinine and artesunate. These can kill. Okay, gametocytocidal. All right. Coming next to, I know this could get a little boring. This is again second year revision. Chemical classification, that is the pharmacological classification. Pharmacological classification. In pharmacological classification, we will be saying first what are the Cinchona alkaloids. Okay, Cinchona alkaloids. Cinchona alkaloids. Cinchona alkaloids are quinine and quinidine. Quinine and quinidine. Then second is quinolone derivatives. Quinolone derivatives. In quinolone derivatives, we have 3 types. Okay. Number 1 is 4 aminoquinolines. Then we have 8 aminoquinolines and we have quinoline methanol. Quinoline methanol. So in 4 aminoquinolines, we have chloroquine, amodiaquine, and we have pyronaridine. Okay. In 8 aminoquinoline, we have primaquine, tafenoquine and bulaquine. And in quinolone methanol, we have mefloquine. Alright, this is done. Number 2 is done. Number 3 is phenanthrene methanol. Phenanthrene methanol. In phenanthrene methanol, we have halofurantin and lumefurantin. Okay. Then number 4, we have antifolates. In antifolates also again we have 3 types. Biguanides. In biguanides we have proguanil. Okay. In diaminopyrimidines, diaminopyrimidines, we have pyrimethamine. I know this can get a little bit tedious, but what to do, we have to know. Okay. And then we have sulfonamides. Last, sulfonamides, very easy to guess. Sulfadoxine. Sulfadoxine. Okay, this is about the antifolates. Number 5, we have artemisinin compounds. Artemisinin compounds. What are the artemisinin compounds? You know, artesunate, artether, artemether. Okay. Then coming last, we have antimicrobials. Some antimicrobials also have an anti-malarial action. Okay. Which ones? Doxycycline, clindamycin and atovaquone. Okay. This is about the drugs. Now we will read a little bit about the yeah, all right. Now coming to treatment per se, the regimens. Okay, I'll be talking about with you in about 3 to 4 regimens. Okay, so number 1 regimen, this is recommended treatment in chloroquine sensitive malaria. chloroquine sensitive malaria. Now, what are the species which are sensitive? P. vivax is sensitive, and chloroquine sensitive falciparum malaria, because there are species now which are, there are few types which are in falciparum there is resistance also. So these are the chloroquine sensitive malaria. May we have P. vivax and chloroquine sensitive P. falciparum. So what is the treatment which we give? We'll give chloroquine 10 mg per kg base stat. This is orally, followed by 5 mg per kg base, okay, at 6 hours, 24 hours, 48 hours. So total dose becomes 25. Okay, 1 2 3 15 plus 10, so we have 25. Then otherwise you can follow another regimen which we follow commonly. Chloroquine 10 mg per kg base stat orally, followed by 10 mg per kg base stat at 20, sorry, not stat, how does stat come here? At per kg base at 24 hours, and 5 mg per kg base at 48 hours. So total becomes again 25. So that is how you can give. Now along with this, now in chloroquine sensitive malaria, right? So you have given this. Along with this, what should we give? We should give definitely primaquine. So in Vivax, what do we give? To prevent relapse, you will give 0.25 to 0.50 mg per kg once daily for 14 days. You give Vivax. This is to prevent relapse. This will kill what? Hypnozoites, sorry. It will kill hypnozoites. And in falciparum, you will use 0.75 mg per kg, okay, stat dose, that is single dose, okay. This is for gametocidal action. Okay, gametocidal action, and this gametocidal action therefore prevents what? Recrudescence, basically. So coming down, then again the disease again spreading. Okay, now the thing is, primaquine is contraindicated in infants, and in one more whom? G6PD deficiency. You should not give. Okay, in infants and in G6PD deficiency, it's contraindicated. Okay, now an interesting point is, if there is vomiting within 45 minutes of taking of chloroquine, you can repeat the dose with antiemetic. Okay, and it's better to give this after the meal and when afebrile. All right, so that is a thing which you can do. Now you need to remember this for every time, like for Vivax and falciparum, this doses of primaquine. Okay, this is primaquine. This is also primaquine. Okay, primaquine is available as 2.5, 5 mg, 7.5 mg, 15 mg tablets. So you can definitely adjust the dose. Now number 2 regimen, recommended treatment for chloroquine resistant malaria. Chloroquine resistant malaria. But which one is this? P. falciparum. Sometimes we use it even for P. vivax, which has not responded to chloroquine. Okay, we can use this. All right, not responded to chloroquine. Chloroquine sensitive regimen. If it did not respond to chloroquine sensitive regimen, you can use this. Okay, this is chloroquine resistant malaria. So in this also there are many things to discuss. Number 1, we can give artesunate. Artesunate is IV, right? 4 mg per kg OD into 3 days. Along with this, we can combine a single administration of sulfadoxine pyrimethamine as 25 mg per kg of sulfadoxine plus 1.25 mg per kg of pyrimethamine on day 1. Okay, this is one thing which you can do. Or same way artesunate as we gave above, that is 4 mg per kg OD, 4 mg per kg OD, okay, into 3 days. Along with this, instead of that single dose of SP, we can give mefloquine, which is given 25 mg per kg in 2 divided doses. How do we divide the dose? We give it on day 2 and day 3. On day 2 we give 15 mg per kg and on day 3 we give 10 mg per kg. Okay, if no easier method, or the most commonly method which is followed even in my hospital and in many private clinics also, we can follow this. What is there? There is co-formulated tablets, which are given with fatty food, especially like milk, for better absorption. That is our ADME, which is pharmacokinetics of the drug. So co-formulated tablets which contain 20 mg artemether with 120 mg lumefantrine. Okay, lumefantrine. It's a 6-dose regimen for 3 days. Means every day you will take twice. Okay, 3 days. So how do you divide is 5 to 14 kgs child will be taking 1 tab BD into 3 days of what? 20 mg artemether, 120 mg lumefantrine. 15 to 24 kg will be taking 2 tab BD into 3 days. 25 to 34 kgs will be taking 3 tabs BD into 3 days. And more than equal to 35 kg will be taking 4 tab BD into 3 days. Along with this, same way you should give primaquine. How you know how to give for Vivax and how to give for falciparum I've already explained. What you need to remember is this should be given along with fatty food like milk. Okay, it's better for absorption. Okay, done. Second one done. Now number 3 regimen. This is recommended treatment for MDR malaria, multi-drug resistant. Means what? What do you mean by multi-drug resistant malaria? Which is resistant to both chloroquine and sulfadoxine pyrimethamine combination. Okay, so this is most likely going to be a falciparum. So what do we do in this case, in this scenario? We give the same combination, that is artemether lumefantrine combination you can give as described above. This one we described, right? This entire thing, co-formulated tablets, you can give this. Okay, or you can go for artemether mefloquine combinations which are available. Okay, or you can go for quinine which is 10 mg per kg salt dose. It's not the base, it's salt dose orally, TID. For how many days? For 7 days. Okay, if the child develops synchronism, you can give only for 3 days. Synchronism you give only for 3 to 5 days. Okay, along with this quinine you need to combine what? You can combine any of the 3. What any of the 3? You can combine tetracycline, you can combine doxycycline, or you can combine clindamycin. Along with what? Along with quinine. So one regimen is artemether lumefantrine, one measure is artemether mefloquine, and one measure is quinine plus either tetracycline, quinine plus doxycycline, or quinine plus clindamycin. Now what are the doses? Dexa, this should be used above 8 years. Yes, you know that. And uh, what is the dose? Tetracycline is 4 mg per kg per dose QID for 7 days. Doxycycline is at 3.5 mg per kg daily into 7 days. And clindamycin is 20 mg per kg per day in 2 divided doses, or 10 mg per kg BD, basically 2 divided doses, and this is also 7 days. Okay, this is also 7 days. Okay, this is done. Recommended treatment for MDR falciparum malaria, which is resistant to both chloroquine and sulfadoxine pyrimethamine. And along with this, again you will give primaquine. You know how to give primaquine for falciparum, that is single dose. Okay, now next, lastly, I'll discuss the fourth regimen, which is very important. Recommended treatment for complicated or severe malaria, be whatever species, most likely 90% it is going to be falciparum malaria, but sometimes vivax also can present with a severe form. Very unlikely, but it can present. So recommended treatment, you can give artesunate, which is, now this treatment is going to be mostly IV. Start with IV and gradually it can become oral. In artesunate, less than 20 kgs, more than 20 kgs. Okay, less than 20 kg, more than 20 kg. In more than 20 kgs, it is 2.4 mg per kg per dose. You need to remember per dose how much. And in less than 20 kg, most of the authors mention 3 mg, but very few authors follow 3.2 also. So, and 3.2 mg per kg per dose. Okay, when all do we give? We give IV, we give stat, that is at 0 hour. So when all do we give? IV at 0 hour, then 12th hour, then 24th hour. Okay, these 3 doses are over. Then once a day for 7 days. Once a day for 7 days. Okay, so total this comes to 10 doses actually. 10 doses. Okay, and another thing which you can use is artemether. Artemether is also 3.2 mg per kg loading dose IM stat, followed by 1.6 mg per kg daily IM for 7 days. Now both these above, artesunate or artemether, can be changed to oral form after minimum of 24 hours. Okay, this is if the patient can swallow. Okay, and once you see, when if you convert it on the after 24 hours immediately when the child can swallow. But if it's not, you continue the IV treatment for 7 days. Don't change in between to oral. It's better not to. Okay, because one drug is acting, you have given 6 doses of artesunate and then you're suddenly changing to oral for 3 days. Oh, it doesn't make sense. Okay, along with this is artemisinin combined therapy, so don't forget. So this is artemisinin component. Now combined therapy, the same thing which you can use as this. In combined therapy, you can combine this. The same thing orally you can add to this artesunate or artemether, whichever you are following. You can add tetracycline or doxycycline or clindamycin along with these. So this will complete the artemisinin combined therapy. This is to be given orally. All right. Now other thing what you can give, sometimes artesunate artemether resistance is there. So sometimes they don't respond to this. In cat cases, what do we use? Our hospital struggles, government hospitals struggle to get this IV injection, quinine. This injection quinine 20 mg per kg loading dose is given. If all this doesn't work, in 10 ml isotonic fluid, preferably dextrose, because it's going to cause hypoglycemia. 10 ml per kg fluid, 10 ml per kg fluid by infusion you can give over 4 hours. After 12 hours, you give again another dose of 10 mg per kg, but this time over 2 hours. This is maintenance dose. Maintenance dose. So 20 mg per kg loading and 10 ml isotonic fluid per kg by infusion over 4 hours, followed by 12 hours 10 mg per kg over 2 hours maintenance dose. The maintenance dose is repeated every 8 hours. Every 8 hours you should repeat this maintenance dose until the patient can swallow. And once the patient can swallow, you can give quinine tablets which are 10 mg per kg 8 hourly to complete a 7-day course. 7-day course. And you should add accordingly. Again with quinine, what you will add? You will add tetracycline, doxycycline or clindamycin. Okay, one of these, same thing again comes. So remember, it's a combined therapy. Okay, you should combine with either of these three. Okay, done. We are clear about the treatment of the 4 regimens, right? Now we will be going towards a little mention about chemoprophylaxis, which is the last topic. Chemoprophylaxis. Chemoprophylaxis. So what is chemoprophylaxis? Chemoprophylaxis is when someone is going from a normal area to an endemic area, going to travel to it. Okay, they take a chemoprophylaxis and go. So that will prevent the occurrence of malaria in them. So it depends on the amount of stay. Okay, is it going to be a short stay or is it going to be a long stay? Okay, is it going to be a short stay or long stay? A short stay is defined as, what is the definition of short stay? What is the cutoff? 6 weeks. If it's less than equal to 6 weeks, it's short stay. If more than 6 weeks, it is long stay. So for short stay, what do we take? Short stay, we give doxycycline. We give doxycycline, that is 1.5 mg per kg OD. Every day OD. Okay, and it is started 2 days before travel. 2 days before travel, and continued up till when? Continued up to 4 weeks after the travel, after leaving the area. After leaving the area, you will continue it for even 4 weeks. So total you are giving for -2 to +4 weeks. -2 days to +4 weeks. In this, between this, he is going and coming, okay, to the area. Now if suppose it's a long stay, that is more than 6 weeks stay, your drug of choice for long stay is, for chemoprophylaxis, is mefloquine. Mefloquine is nothing but 5 mg per kg once a week. Because it's a longer stay, you cannot keep taking daily. So mefloquine is a better drug which you take once a week. So it's 5 mg per kg. In this you have to start, same 2 and 4 is coming, but not 2 days. It's 2 weeks before. 2 weeks before till 4 weeks after the exposure, after the assumed exposure. Okay, so this is about the chemoprophylaxis. So this is what is concluding on malaria. Now you must have understood like what all I have explained in the entire sessions. So basically what you need to know is, along with this you will have the ancillary treatment, like in a very sick case, ABC we need to follow. You need to correct shock, you need to ventilate sometimes, you need to sometimes even give head and elevation, decrease raised ICP features, treat the raised ICP, treat the shock, okay, treat the fever, okay, and sometimes IV PCM you'll be giving, sometimes suppositories you'll be giving, sometimes oral treatment in stable patients. Okay, this is all the ancillary treatment, basically ABC and all the other things. Okay, generalized treatment. And one thing not to forget is primaquine, which you have to give for Vivax and falciparum. Vivax is 14 days and falciparum is single dose, and the doses are different for both. So we explained a little about introduction, in which we spoke about the drug resistance, and we spoke about the etiology organisms, and we spoke about the life cycle. We spoke about the pathophysiology, a little bit detailed about it, like which cytokines are involved, and we described the clinical features, what are the types: initial infection, recurrent infection, and the types of recurrent infections which can happen. We have described the classical features, overall what can be present, and then we have even explained what is severe malaria, what is complicated malaria, all right. And then we have described a little about each of the complications, like severe anemia, hypoglycemia, acid base changes, renal complications, respiratory complications, cerebral malaria, malarial retinopathy, a little detail I have shown you photos also. And then we discussed about tropical splenomegaly syndrome, the congenital malaria. Okay, then today we spoke about the diagnosis, the microscopy, all right, how the smears are made and what do we see in that. Okay, so I forgot to tell one thing over here. The reporting is done generally as PFR, PG, sorry, PFR, PVT, PFG. Okay, PFR is nothing but Plasmodium falciparum ring form, Plasmodium falciparum gametocyte. Okay, Plasmodium vivax trophozoite. Okay, like this we can be in many labs they report sometimes like this, and like the smears are reported to be positive for this. Okay, or else it's negative. And you need to remember about the antigen detection and what are all the antigens we are using. Okay, and then the DNA probes, PCR, flow cytometry use, antibody detection, and I mentioned about this personal experience of leukomoid reaction which you have seen. Okay, and in treatment we have classified the drugs first in clinical classification, and we have classified pharmacologically as well. Okay, clinical and pharmacological classification. And then we have described regimens of chloroquine sensitive malaria, we have described chloroquine resistant malaria, we have described about the multi-drug resistant malaria which is defined as chloroquine as well as SP. Okay, and then for complicated or severe malaria, which is a we have the criteria for it. Okay, and then we discuss a little bit about the chemoprophylaxis. So again, coming to thank you for listening. I know like my videos get a little bit tedious and detailed, but that is what my aim was when I started, and I thought I'll make videos. I wanted to make videos for postgraduates because as a postgraduate myself, I was not able to find detailed videos which I could use for my postgraduate preparation, post-graduation preparation. So thank you very much. Like always, I would like to tell you the sources. So the sources for my presentation definitely is one is IAP infectious diseases, IAP infectious diseases, okay, which is a textbook having all the infections, and that I have taken the regimens from there itself. And even the treatment of hypoglycemia is very well mentioned there, that 25 ml per 25D and the 5D. So and that one, and plus for most of my pathophysiology I have taken Feigen and Cherry, which is a textbook of pediatric infectious diseases. Okay, there is another IAP textbook called IAP diseases of tropical infections, IAP tropical infections diseases. It is also a very interesting read, but it gets detailed. Okay, I did not mention a little bit about algae and malaria and all that, which is okay. And we did not discuss as such differentials and all this, but okay, our discussion was quite detailed. So thank you very much. This is Dr. Waheed Hussain. I'm signing off now, and please like and subscribe if you have made use of this video, and please recommend it to your other friends. Okay, thank you very much. Thank you.